for today. We have like 2 hours blocked off. I wanted to take the first hour just to kind of talk through ACL rehab. We have all either are in the process of going through school or are all currently treating now. So with this, I'm going to talk about some stuff that may be a little bit redundant, but it should provide some good context for when we get to the Q&A section. So some of this might be new for you. A lot of it will be review, but I think it'll give you a good idea as to how we approach ACL rehab at our clinic. And it should set the table for some really good discussion in Q&A, which I'm hoping this is less lecture style and more just kind of informal conversation, where if you guys want to kind of deep dive into some of the specifics, we can do that. And I can give you just some of what my experiences are after practicing for the last 8 years. So Chris has my PowerPoint pulled up. This is the one that I used for our online summit. So I'm one of the presenters and founders for R2P Academy, the continuing education company. So I did this presentation previously. So if you've seen it, I'm not going to go through the entire thing like I did at the online summit. I'm going to breeze through some of the early stuff. And then at the end, it has a phase-by-phase ACL progression. And that's really where we're going to spend the most time on. Chris is going to kind of click through for me. So I apologize. I'll try to make it as efficient as possible. But if stuff isn't lining up, just flag me down or wave me down, and we'll make it work from there. Question-wise, I'm open to anything. If we're going through something and you want me to stop and repeat or slow down, just get my attention somehow. I don't know if that involves them letting you, Chris, know as the host and then you waving me down, or if you just want to write stuff down, we'll have plenty of time at the end to talk as well. So, Chris, if you don't mind just clicking through. So I do not know most of the people here. So to give you a little bit of a background about me, I'm Zach Baker. I'm a physical therapist. I work with Rehab to Perform. We are a PT clinic in Maryland. We have 4 different locations in the greater DC and Baltimore area. Dr. Josh Funk is the owner of the company. Him and I were classmates at University of Maryland. So him and I started the company up together about 6 years ago. And since then, my role has kind of changed from just him and I being the 2 PTs, treating everyone and doing all the front desk administrative work and billing and behind the scenes, to now we have a 4-location company. I still actively treat 30 hours a week. And in the other time, my official title is Area Director. So I oversee the Frederick and Mount Airy locations. And I do a lot of the community outreach, networking, behind the scene business stuff. I do a lot of like the financial metrics and clinical metrics in the clinic as well. So if anybody has any interest in that, feel free to reach out to me and we can talk about that as well. Most recently though, the biggest task that I've taken on is we have actually developed and started a sports residency at Rehab to Perform. So I got board certified a couple of years ago. I spent the last 1.5 years developing our residency program. And we actually just got granted initial accreditation through the ABPTRFE, the Board of Physical Therapy Residency and Fellowship Examiners. So in 2.5 weeks, September 8th, we actually take our first cohort coming in. So we will have a residency program here. My title with that, I'm the program director for it. So I oversee all of it. I do the curricular design, and we'll be implementing it with our first resident this fall. So I'm actually pretty excited about that. I was born and raised in Carroll County. It is a kind of a small rural county in Maryland. Like I said, I'm the area director here and the program director. Prior to PT school, I got my bachelor's at Salisbury University in Maryland, got certified as a strength and conditioning specialist. I originally wanted to go more into the like college training room, sports performance route. In high school and college though, I had 2 ACL injuries. I also had bilateral shoulder dislocation. So I have labrum and rotator cuff tears in each shoulder, along with 2 ACL injuries. I managed to pack that in about 3.5 years' time. So that was really what got me more away from the strength conditioning career field and more into the PT field. So I went on to University of Maryland, graduated in 2012. And my special interest is traumatic and post-op injuries. So I love doing post-surgical work. ACL, I have a specific passion for. We see a high volume of ACL injuries. I would say in the 5 years that I've been here at Reactive Perform, I've probably treated about 400 to 500. So we see a very, very large number of them. So my clinical affiliations, when I was in PT school, I was with the Fisher Institute out in Phoenix, Arizona. They are a private practice clinic that's owned by Brett Fisher, who's the sports medicine director for the Arizona Cardinals. So they also do off-season MLB training and NFL combine training. In the picture, that is my wife, Britt, my 2 daughters, Reese and Quinn. They are 6 and 4 years old. And 2 weeks ago, I just had a little baby boy named Luke. So we got a full house right now between the 3 kids, and we got a couple dogs running around the house too. Chris, if you want to go to the next one. Objectives, we can skip through this. We don't need to go through that. Why are we here today? You can go through that as well. So for this, this was kind of touching on when I was doing the topic. The main reasons that we were trying to get through this was really people were either there expanding clinical knowledge, trying to figure out how to return athletes to competition in the best physical and mental state possible. How do we do this in a very systematic way so that we can just objectively check off boxes as opposed to just blindly going through a protocol, and trying to figure out how do we blend that art and science of rehab. And then also just how do we reduce the legal aspect of things and make sure that we are not putting ourselves in a position where we are taking on too much risk with our return to sport or discharge decision-making with ACL patients. And we can go to the next. All right, so with this, who do we have here? And obviously here we have more of our medical side, but when I was presenting this earlier, we talked about when you're treating ACLs, you've got a large group of people who are all involved with this. You have the patient at the top, and then underneath of that, you have everybody involved with the patient. So we have our non-medical side, and this is when we talk about like friends and family and teammates and coaches and all of the people that are not providing care, but they're playing a very large role in the rehab process, either just communicating with that individual on a daily basis, giving them information, whether it is good or bad, whether it's, teammates who have had the surgery before, or coaches who have expectations, friends and family who are getting them to and from. So a lot of people that you're going to interact with that really have no direct involvement in patient care, but in the whole patient experience. On the other side where we fall, this is more that performance and or medical team. And I divided this into more of like your strength conditioning or more of the medical side, your physicians, PTs and PTAs and ATCs. A lot of that's just going to deal with what setting are we involved in? Are we in more of a private practice outpatient setting, or are we functioning within a university, collegiate, or professional setting? So I like to put that diagram up there. There are a lot more people than just the PT, the surgeon, and the patient who are involved. Click on over. We can go through this. This was just talking about how we have a lot of evidence out there that says we rehab a lot of post-surgical conditions, but we don't always do the best job with it. So if you're scrolling through that, that was just some references that I used. That's not exclusive to ACL injuries. There is some stuff in there about rotator cuff and labrum repairs, hip arthroscopies, ankle broadstrom repairs. So really that summative of all of that is just saying we do a lot of rehab for post-operative patients, but we really don't have a definitive consensus on what we think is best practice, or we don't really have the most desirable outcomes all the time as well. We can head to the next one. It should be another slide talking about evidence, so we can go through that as well. So really it comes down to how can we improve on this? So switch over to the next slide. The saying that I always tell all of my students, so I still take DPT students as well. We have clinical affiliations here at Reactive Perform. We actually have a guy from Pittsburgh right now. and another one from University of Maryland at the Mount Airy clinic I'm in right now. And a lot of students get bored by rehab from the post-operative standpoint. And they say it's redundant. They say it's repetitive. They feel like they're kind of handcuffed by the protocol. I like to always say, tell me the rules of the game, and we're going to play this game better than anyone else. Meaning, I want the surgeon to tell me what we are definitively not allowed to do, give us our anchor points of what we can and cannot do, and then within those constraints, we're going to figure out how we optimize that process. And we optimize that process through programming and developing a very synergistic plan of care that's going to have a cascading effect as we move throughout the phases of rehab. And you'll get a better picture of what that means as we go further on into this. So we can click to the next. So really it comes down to how do we put the pieces together is what that beautiful graphic is that I put in there. You guys are going to find out I do not have the most visually appealing PowerPoint, so bear with me. It's more content driven. I'm not going to win any graphic design awards. Chris, we can go to the next one. General surgical considerations. So, you know, when you're in clinic, when you're out of school, I'm assuming most people here are still in PT school, but I know Chris said we may have some people through the Level Up group or just through some other networking measures that have made their way onto this Zoom call as well, who may be treating. But I always like to figure out, you know, who the surgeon was. Do I have any relationship or rapport with them? This may guide how aggressive or how conservative I am with them. In our area, there's a handful of surgeons that we see a high volume of patients with that. With them, it's to the point now where they know how we function. They know how we operate at our clinic. And they basically say, Zach, here's my ACL patient. This is when their surgery was. I don't want you running or doing impact until this date. Up until then, do whatever you see as best fit. And we have a lot of leniency with that. We have some other surgeons that we'll get patients from, and they are very definitive as to what they want us doing and what they don't want them doing, and whether there is evidence to suggest that that's best practice or not. They're still very adamant about how they want that patient treated. If it is something that I see as just not really being in their best interest or standard practice, I do my best just to reach out to the surgeon. Sometimes there is more going on with the patient than what we see on a protocol or a script, and that may be why they have some of those safeguards in place. Other times it may just be that they're not familiar with your clinic and they're afraid that you may do too much with them or that you just don't have the experience working with them. But one thing that I would encourage students to do as you get into the working world, try to contact physicians, and you may not always get in touch with their office, but at least leave them a message and just, you know, give them a thought of what your idea is or what your plan is. It may get shut down, and if so, you just got to kind of roll with it. But we had a surgeon one time who was very adamant about not letting any of his ACL patients return to playing until 1 year post-op, no matter how good, how bad they were doing. So we actually invited him out to come and see a session with one of his patients who was about 9 months out, who we thought was doing very, very well. And when the surgeon came out and saw how we operated and how we were taking them through their rehab sessions and all the different boxes that we were checking off, we got a lot more leniency with that surgeon. So don't be afraid to reach out, but appreciate that sometimes you are going to have your hands tied by the other people involved in the process. Boom, boom. You can go on to the next one. All right, rehab training considerations. This is another just kind of quote that I always try to tell people. You know, the purpose of rehab or training is to get this individual back to their desired state of physical and mental competency. And with this, it's kind of that blend of, you know, certain things that you want the patient to be able to do. You know, certain things that the protocol wants them to be able to do. But you also have to figure out, what are their goals? What do they want to get back to doing? What's their end game? As we get to that end stage rehab, when do we know when to stop? And I think that's where, when we talk about PT, we do a very good job in PT school and as PTs of learning how to handle that first 3 months of rehab. But I know when I came out of school, I kind of had this gray area of like, when do we stop? When do we discharge? When is enough enough? When do we hand off to a strength coach or a personal trainer? And we'll get into a little bit of that later on. But a few big things that I like to talk about early on. And I think if you look at these considerations, it really frames up the whole mindset. But we want to define and describe what their desired activity level and competition entails. And really with this, what is their sport or activity? What level are they competing at? Meaning, is it recreational or club, or is it professional? What are the demands of this sport from a physiological and biomechanical standpoint? And if you can figure out what they need to get back to, it makes programming much easier. And I'll show you what that means when we talk about kind of qualifying activities and how we qualify interventions as well. So if we know what they need to get back to, the next thing that we have to do is we have to determine what's their starting point. Post-op's pretty easy. A lot of times they have surgery August 1st. You see them anywhere from 3 to 10 days later, and it's a pretty definitive starting point. Other times, I know in our clinic, we get a lot of people who are like 3 or 4 months out, and they're transitioning to our clinic because they've kind of tapped out what they could do at their previous clinic, and they wanted a more, kind of sports-oriented approach. So we have to really define where are we at from a starting point from a timeline standpoint, but also from a functional standpoint as well. Length of time to accomplish this goals. What's our sense of urgency with this person? I will have individuals that may need to go back to sport sooner than others, whether because they are a freshman in high school or maybe a senior in college. And we'll get to 2 case studies at the end that's going to illustrate this. But I think you need to appreciate, is this somebody that maybe they're a freshman in high school, we know they're going to play collegiately beyond high school. So the risk reward of getting them back at 9 months or 8 months or whatever, there's really no benefit to going back at 9 months versus a year or a little bit over a year. Whereas if I have a professional athlete who's in the last year of their contract, and maybe their contract has some performance metrics built into it, and if they make certain teams or if they hit certain stats, they make a few more $1 million, and their season starts in 8 months, you're probably not going to make too many people happy if you just tell them right from the start, there's no way you're going to clear them at 8 months and they need to wait a full year until they get back. So just appreciating what kind of sense of urgency we have, and really complicating factors is going to play a role in that. What are my definitive parameters, limiting factors? What can I manipulate at will? This kind of goes hand in hand with, what does the protocol say I can do? What does the surgeon say I can do? What things can I push the envelope with early on, or which things do I just need to kind of hold off on? And Chris, we can go to the next slide. No 2 injuries are the same. We'll get into that. Mechanism of injury, confidence, apprehension. That'll be stuff that we'll probably get into with the Q&A. So we can go on to that later on. We can go through this. All right. So phase-based continuum of care. I think this is very important to understand, and this is a very good graphic. If you guys, I know this is being recorded, if you want to screenshot it, this graphic, it's not unique to me. I found it on Google and it matched up well with what we were doing. But if you want to take a look at this, I think it's pretty important to note that we have certain things that we are trying to accomplish at different phases of the rehab process. We have different people who play a very large role in that process. And then those people have pretty definitive goals within each phase. So as we go through this, you're going to see some terminology that I use for the phase-based rehab that we just kind of use that terminology at our clinic. It's not something that's exclusive. It's not something that you need to memorize. It really just helped provide a framework for us. But if you want to think of this in a nutshell, just think of at the very top process where it says medical treatment, we are going from things that are very kind of bread and butter, PT school oriented, and we're working further down the spectrum to get to more sport specific tasks. As we start in that medical treatment, this is where we are more physician, PT, on the spectrum. That's where we get more into our strength and conditioning, personal trainers. And then obviously, if you have a background in that, that may dictate how long you hold on to a patient versus when you may tap out and refer to somebody that you think can fill in those gaps a little bit more efficiently than you can. And then the other thing that we'll touch on later on is within each one of these phases, so the medical treatment, the rehab, the end stage rehab, what are we actually trying to accomplish in one of those? And then how are we actually monitoring, measuring that? So Chris, we can go to the next one. All right, defining and characterizing activity. This is something that I think is very important, and I think it'll get you out of the mindset of just trying to memorize exercises and memorize protocols of what to do with people in certain phases. So that's kind of the how and why we do this. It's really essential to understanding what our individual needs, but more importantly, what may be a limiting factor as to why they're not tolerating an exercise from a pain standpoint, or why they might not be competent with a certain exercise. So it provides us a very logical way to program for an individual, and it also provides a very logical way for us to progress, regress, or lateralize an individual's program. All right, so on this is not an exclusive list or an all-inclusive list. You could put a bunch of different defining characteristics onto it. But if we are talking in a very general sense, I would say the items on the left-hand column, that single joint and down, tend to be more of your basic remedial, easier things to accomplish. On the right-hand side of the column are your things that are a little bit more advanced or a little bit more technically demanding or just physically taxing. When we are defining what an individual is trying to get back to doing, these are some descriptive terms that I like to go through to help guide that decision making. So if I were to use an example like running, running involves multiple joints. It's not single joint. You're going through multiple planes of active motion. It's a dynamic as opposed to a static task. It is asymmetrical as opposed to symmetrical. And when I think of that, you could kind of qualify that term in a variety of different ways, but for the purpose of what I'm talking about, the left and right side of our body are not doing the exact same thing. So if you think about doing like a bench press or a push-up, your left and right arm are doing the exact same thing. If we're throwing a baseball, that's a highly asymmetrical motion. Running, weight bearing versus non-weight bearing. There's a degree of higher velocity than lower velocity, impact, more impact than low impact. When we get down to this bottom, this is where we start to get into more of that like end stage rehab. Is it unstructured or structured? Meaning, if I'm running in a track meet and I'm running a 100-meter dash, that's a very structured environment. I know where I'm starting, where I'm finishing, and I know when it's going to take place. It's going to happen when they blow the whistle or shoot the gun. If I'm running on a soccer field, it's very unstructured. I don't know exactly where I'm going. It's dependent on my player or the ball. And I don't really know how fast or what direction I'm going either. Contact versus non-contact, and then the whole concept of reactive versus anticipatory. So reactive meaning, is it something that I'm responding to an auditory or a visual cue, or is it anticipatory where I have a defined starting and stopping mechanism? So the reason I go through all of that, when I went through my ACL rehab, I can vividly remember getting ready to run at like that 3-month mark. And we just said that running requires pretty much everything on this right-hand column. The exercises that I was doing, and looking back on it, and I know it's been about 10 years since I had my ACL done, but looking back on it now, I'd like to think we've come a little bit further within our rehab spectrum. But I also just think part of the reason I had a re-tear in my ACL was just poor programming and preparation. I was doing things like straight leg raises. I was doing clamshells. I was doing bridges. I was doing just a lot of very basic activities that would fall into either a single joint, a single plane, a non-weight bearing, a low impact category. And then I was getting asked to go into running where we're introducing all these new variables. If I were to have pain, we would have no clue if it's because we went from single plane to multi-plane, static to dynamic, non-weight bearing to weight bearing, low impact to high impact. So the good thing about ACL rehab is you get a very longitudinal, linear approach to periodize somebody's programming. And you have the ability to manipulate maybe just 1 or 2 variables at a time, compared to somebody who may have chronic back pain, and you're only going to see them 3 or 4 times in the clinic, and you need to try to cover a whole lot of exercises or a whole lot of information in a condensed time frame. Chris, we can slide to the next one. So these were some slides that had videos on there. When I was sharing this with Chris, I gave this to him late, so I didn't have time to give him access to everything, but just to kind of hammer home what I talked about, Chris, if you want to play this video, this is just a video of one of our interns doing a bridge variation. If you had to qualify this task, I would say it's bilateral, it is symmetrical, it's quasi weight bearing. There's a weight bearing degree to it, but he's not full weight bearing. It's low resistance, it's anticipatory, it's static in the sense that he's not changing position, but he is moving. He's not just staying perfectly still like an isometric, but you kind of get the idea. Chris, if we go to the next one. So the next one, this is one of our PTs in Mount Airy staff, and the video is just her doing a single leg bridge. Every single part of that exercise is the same, except we went from bilateral to unilateral, or you could also say we went from a symmetrical to an asymmetrical activity. So if Steph was not able to perform this task, or she started having pain with the task, it'd be very easy to figure out where that may have happened. Going over to the next slide, I believe. All right, perfect. In this one, she was doing a single leg RDL. So we went from minimal weight bearing to full weight bearing. We went from bilateral to unilateral, or from a 2-legged stance to a single leg stance. So we're adding in more multi-planar control. We're adding in more stance demands. Chris, if you want to go to the next one, I believe it should be, with this one, she was running diagonally and cutting from cone to cone. My purpose with that was that we went to an impact-related task with some change of direction, but it was still structured and anticipatory, meaning she knew exactly where she was going and what she was doing. And then if you want to go to the next one, Chris, this one we can actually play the video. This was an ACL patient of mine. She's a Division I lacrosse player. With this, the drill was for my college intern to approach her, and then he either had to make a move to the left or the right. So Cassie did not know where Brad was going. So she had to run up to him, react to his movement, shuffle with him, and there's contact as well. She's actually initiating contact and riding out with him. So that pretty much covers all of those different right-sided columns that we were talking about. And you can see we went from very remedial exercises to pretty high-level exercises. Chris, going to the next one. Functional testing, this is just examples of different testing that we do, but we can skip through this because we're gonna have some context. Return to sport decision-making. With this, we'll get more Q&A with this, but we're really talking about impairment and functional-based criteria. If somebody's gonna be returning to sport after ACL rehab, we need to make sure that they look the part. What's their range of motion look like? What's their strength look like? What's their power, their overall fitness from an aerobic and an anaerobic ability look like? Psychological readiness, we use the ACL RSI scale, and that is a series of a questionnaire with a series of questions that ask them in different ways how comfortable and how confident are they with their knee. I've had people who have crushed our battery of return to sport testing, and then we've given them that ACL RSI, and they are only 50% confident in actually returning to sport. And it's something that if you didn't have that conversation with them, on paper they would have looked good and you would have put them back out there, and they may not have mentally been ready for it. And then also just legal and ethical considerations. This is more kind of thinking outside the box, but are you in an environment where you have the ability to make that return to sport decision? Or are you the person who is deferring to the surgeon? Are you deferring to maybe the head athletic trainer at their school? Where does that decision-making process fall? And I would say ultimately, don't forget that we're not really telling somebody if they can or cannot play. We are providing them unbiased information that is telling them how ready they are to successfully return to sport. But ultimately, it's the patient's decision to take your information, the information from the physician and from all the other people who are providing them, and make their own intelligent decision off of that. We can
Zach,
go to the next one.
there,
Yep.
Travis Paulin had a question about what would your plan be with the patient who clears functional testing but fails the ACL RSI?
Yep. So what we do at our clinic, we actually utilize that RSI early on. So we do it in the very beginning. And in all honesty, they have a 0 on the test in the very beginning because none of the questions even apply to them. And then we examine that at the 3-month mark, at the 6-month mark. And then after 6 months, we just do it every month. So ideally with that, it's typically in our environment, it's not something that we're ever blindsided by. So it's something that if we're noticing there's a disconnect between their physical readiness and their mental readiness, you're catching that pretty early on at the 3-month mark. And from there, sometimes it's conversations that you have with them. Sometimes it is the recommendation or the referral out maybe to like a sports psychologist or just somebody else that can provide more of that component to the rehab than what you can if you feel like you've had the appropriate conversations and have given them all the information that they need, and you just feel like you've tapped out your resources. But I would say use that ACL RSI or another comparable measurement tool early on in the process, and then you're monitoring it before you ever get to that end stage. All right, return to sport decision making. With this, we are doing different functional criteria. We're touching on how symptomatic they are, what does their joint stability, tissue quality look like, range of motion and mobility, strength, balance. I would argue 1, 2, 3, 4, the first 5 things in there, if you have not learned enough of those tests in PT school, then you have either not been paying attention or you need to find a new PT school. You should feel more than comfortable with any of those tests. I think what we need to do, though, is figure out when do we do those and what do those actually mean when they're passing those tests? And then can we arm ourselves with enough tools that look at power, agility, and physical condition to supplement some of those earlier stage testing that we've done. And really with the return to sport decision making, I always tell people there's no one test that is going to quote unquote clear an athlete. There's no one test that is going to hold you back from telling them that they can continue to do more. And I think the other thing that we need to keep in mind is every test is imperfect. And there's going to be information that a test provides you, but there's going to be a heck of a lot more information that that test does not cover. So the more ways that we can hedge our bets and we can create this battery of tests, it's one of those things you're almost, they always say like in the financial world, diversify your portfolio. Don't have too much cash. Don't have too much stocks, all this different thing. Same thing with the ACL world. Don't put too much stock in the range of motion bucket. Don't put too much stock in the strength bucket. Don't put too much stock in the hop testing bucket. We want to figure out what does this person need to get back to their desired activity? What tests match up with each one of those qualities? And then when we do that test, figure out, all right, what did this tell me? But more importantly, what did it not tell me? And we'll get into that discussion later. And I think, did Travis have a comment or another question?
He was just saying thanks. He appreciated your layout of it.
Okay, perfect. Travis, you are welcome. We will move on to the next one. We talked about that, psychological readiness, how we're gauging that. So this is the ACL RSI. So you can Google it and get a bunch of different forms. I actually have we have an app that we use, and we just keep it on our, we have an iPad that we keep back in the clinic with all of our functional outcomes measures. So we just have them fill that out, and then it auto-populates into their chart in the system that we have. We talked about who has final clearance to play, pressure to participate. That's all pretty self-explanatory. Internal, how do we protect the athlete from themselves? How do we safeguard ourselves for the athlete that just says, oh, no, I'm ready, or no, that doesn't hurt? That's where the testing really comes back to play. There's a lot of times that you'll have people that'll pass all your PT testing, meaning like their range of motion, their circumference testing, they have no pain. But then you get into some of your fitness metrics and they are just horribly deconditioned. And maybe they pass some of their limb symmetry indexes with regards to hop testing or strength testing, not because we did such a good job with rehabbing their injured leg, but because they just haven't done anything all that physically taxing for 6 months, and they've deconditioned to the level where it's not really that hard to look the same as the uninjured leg. And if that doesn't make sense, we will touch on that more in depth with some of the other stuff. But I always like to think about that. How do we protect the athlete from themselves? There's some good normative data out there on aerobic and anaerobic testing, so like a 12-minute run test, or like a Wingate test on a bike, or a Cooper or Bruce protocol, a 300-yard shuttle. And you can literally have them run a 300-yard shuttle and then pull up what is normative data for other NCAA collegiate basketball players, and where do they fall? Are they in the 10th percentile, the 50th percentile, or the 90th percentile? And that's a good way to justify if you think somebody, even though they're passing hop testing or strength testing, are they even in shape to go back to sport? And it's also a good way to justify to insurance companies, when you're maxing out some of your functional outcomes measures like a back index or a lower extremity functional scale, or they're showing they have good range of motion, fitness tests with normative data are a very good way to say, hey, this person is not even operating within the national average of what somebody their age and gender should do for this sport. Chris, we can go to the next one. And I apologize. Is this worthwhile for people, or do you want me just to fast forward to the ACL stuff? Is everybody good with this?
This is great.
Okay, perfect. The START framework, this is really just summarizing a lot of stuff of what we talked about. So START, it's a pretty widely recognized and used framework. I would highly recommend looking at this. When we get to kind of like my list at the end of return to sport checklist, it looks very similar to this. It was just my own verbiage, but you could say it's very similar to this START framework. So this is a great tool to have in your toolbox coming out of school. All right, return to sport checklist. We want to utilize this to track progress throughout rehab. I would encourage all of you to create your own version of what I'm going to show you. Really, because you may or may not agree with some of the stuff that I value or that I prioritize, or what most likely is going to happen. You may just not work in a facility that has the same equipment or layout that I do. And some of what I have created is because I don't have a facility or resources that has some of the stuff that all the literature utilizes as well. So when I go through my checklist and we go through some of the functional testing, just take it at face value and just kind of think of the concepts and the themes that I'm using, but feel free to take it and manipulate it to something that you feel more comfortable with, or just logistically that you can even utilize in your clinic. And really the biggest thing with this, it limits your liability. It mitigates the risk in the event that there's going to be an adverse reaction or an adverse event, meaning a re-tear of the ACL. I hate to tell you guys, one of your patients is going to re-tear their ACL at some point. So I have been practicing for 8 years at Rehab to Perform. We've had somewhere at about 400 to 500 ACL patients come through our clinic. We do a pretty good job of keeping tabs on people. I personally have probably been the primary PT on about 200 to 250 ACL patients here. I can honestly say with a clear conscience, I do not know more than 15 of my patients who have re-torn ACL. So I would say that percentage is well below the national average of that, anywhere from like 25 to 40% of what you are seeing. I am not naive enough to say that what I'm doing is the sole reason to that. I think we also get put in a very good situation because we get we get surgeries from phenomenal surgeons in the area. We get a high volume of surgeries from the Baltimore Ravens team physician, who is the actual medical director for the entire NFL. We have very high quality surgeons in the DC and Baltimore area. So I would say some of the re-tears you will have with individuals may just be because they're coming from a surgeon who doesn't do a lot of ACL surgeries. A lot of the re-tears you'll have will be because maybe they had an incomplete rehab process, which is where our expertise comes in and trying to utilize these checklists. You will have some ACL tears that happen just because they are freak accidents and they're gonna happen, and don't beat yourself up over them. But what I can say is the ACL injuries that I've had, the re-tears that I have had with patients, I've never had a re-tear where I have looked back and said, you know what, we didn't go through an appropriate timeline or length of rehab with what the literature says is appropriate, or we did not go through all of the testing protocol to give them informed consent. Or more importantly, I've had a couple people who have retorn because they returned prior to what a normal standard ACL would be. Maybe they went back at 6 or 7 months, but when they made that decision, myself and the surgeon said, this is not a normal circumstance. It's against traditional medical advice to advise you to go back at 6 months. But I also understand that this is your senior year of college and you're never going to play an organized sport again, and you are comfortable with assuming that risk. So I think if you have this checklist in play, it just lets you go to bed at night with a clear conscience, knowing that everybody involved in the decision has been well informed, and there's been a logical process to date that everybody is on board with. So Chris, we can go to the next one. How are we doing on time? We are at 2:45, perfect. So with these, I'm not gonna read through them all, but make sure, have medical timelines been there? Are physical impairments resolved? Are they mentally ready? Have they been exposed to all the stresses of their sport? Have they returned to their pre-injury status? Most people, especially high school, college, and pro, they're gonna have an idea of how fast they were, how strong they were beforehand. So use that to your advantage. If you have somebody that says they're ready to go back to play football and they used to run a 4.640 and now they run a 4.940, well, guess what? You're not even consistent with what you were able to do prior, so why would you want to go back to play? How do they stack up against their peers? That's normative data. How have all participating parties been made aware, and are there any conflicting interests or complicating factors? So that's my criteria. Feel free to modify that to what you believe is valuable. All right, so what we are going to go through, this is just kind of a make-believe case of a high school soccer player. So we will go to the next slide. All right, so the terminology at the top, don't get caught up on that. Don't try to memorize it. This is just terms that we like to utilize in our clinic, but it's by no means anything that you need to pay attention to. Weeks 1 through 4, you can almost make that synonymous with month 1. When we get to weeks 5 through 8, think of month 2 and so on and so forth. In the first month of rehab, homeostasis restoration, this is just getting them back to baseline. I call this get them back to baseline in the don't screw things up phase. Our goals: protect surgical integrity, gain confidence and just normalize their mental psyche, reduce or resolve symptoms. We're doing that through different means of manual therapy and modality, some non-provocative therapeutic exercise or minimally provocative therapeutic exercise. We want to normalize range of motion with an emphasis on getting knee extension early, encourage as much flexion as tolerated, and that may be dictated by the surgeon's preference, but the majority of surgeons that I've worked with have said, get as much as what's tolerated. You don't need to force the issue, but you don't have any definitive barriers that you cannot go past unless it's multi-ligament involvement or meniscal involvement. And we'll say, for the sake of this conversation, this is an isolated ACL injury, and we are not dealing with meniscal involvement or multi-ligament involvement, because that will skew your timelines and expectations. And then our final goal, we want to optimize just basic ADLs and locomotive patterns. So things that I mean by that, we want them to be walking normal. We want them to be able to get in and out of a chair normal. We want them to be able to go up and down steps normal. So like the 3 big functional patterns I think of in this phase: can we squat? Can we hinge? Can we do step-ups? And those are all daily living, activities of daily living. When I do exercises with patients, I will not tell patients I'm doing squats with them in this phase. I'll tell them we're doing sit-to-stands. So that way you don't get in the semantics of them going back to the surgeon and they said that you had them doing squats in the clinic. but there's no reason why you can't then have them do progressive sit to stands at lower depths, utilizing a box or a chair with different height padding. But with this, long story short, don't do anything dumb, protect the surgical integrity, gain their confidence and build rapport, minimize symptoms, normalize range of motion, optimize walking and ADL. If at the end of month 1, we're walking normal, we have full range of motion, and we're minimally symptomatic, I'm very happy with that. We can go to the next slide. Checkpoints. How do we monitor this? This is your PT School 101. You're doing goniometric measurements. You know if you're hitting these checkpoints if your goniometer is telling you or if your eyeball is telling you. No quad lag with 10 straight leg raises. They should be able to do that. Normal gait from a qualitative standpoint. And then we monitor girth measurements as well. We do a suprapatellar measurement, which is more indicative of swelling in the area. And we do a mid-thigh measurement, which is more indicative of atrophy or the lack of atrophy. And we compare these to their contralateral limb. We'll go to the next one. Treatment. This is where I don't like to dictate treatment with this. You all have different mindsets. You'll have different things. But you know, if we're trying to minimize symptoms, you're going to do anything from an intervention standpoint that minimizes symptoms. So if you want to do manual and modalities, that is fine. From a strength training, we're thinking more along the lines of like neuromuscular re-ed, getting quads, getting hamstrings firing, anything adjacent to the area of interest. Think hips, ankle, core. Those are things that I want to start introducing early on. I will get people moving early on doing like push-ups and TRX rows, modified planks, upper body conditioning. I will try to get them feeling athletic and get them doing some total body reconditioning just in a manner that's not going to irritate their ACL. You know, sit them down in a chair, have them do upper body work. If they're going to do a set of 10 quad sets, then have them superset that with a set of 10 push-ups with their hands on the table. Guess what's happening while they're doing push-ups? They've got their knee in terminal knee extension, and you're basically doing a quad set while you're doing push-ups. So I like to try to find creative ways that we can work their knee and they don't even realize they're working their knee, get them feeling athletic again, get them feeling sweating, get them sweating again, and just start to kind of set the table for what's going to happen later on. Chris, we can go to the next slide. Weeks 5 through 8. This is month 2. We call it athletic foundation. Again, don't worry about that. This is where ideally they have full range of motion. They have minimal pain. They've already shown that they can walk normal. This is where we start getting into more variable body weight movement patterns. So we're doing different functional movement patterns, meaning we're doing step ups, we're doing touchdowns, we're doing squats to different depths, we're doing different hinging patterns. Maybe we're introducing split squats or lateral box squats, meaning like wide stance, shifting our weight to the side. These are all of our fundamental movement patterns that we're just doing with our body weight. And we're trying to introduce these patterns to establish confidence with them, but we don't really need to necessarily worry about loading them up with resistance. Things that are less stance dependent. So think back to the qualities of activity where we talk about like our bilateral versus unilateral activities. In this phase, this is where I'm thinking more of our strength related tasks are going to happen in our bilateral stance, whereas more of our proprioceptive or balance related tasks, that's where we're going to transition into our asymmetrical. So think maybe like a tandem stance or a staggered stance, or even a true unilateral stance. We're continuing our total body reconditioning. And the other thing that we are utilizing in this phase at our clinic is BFR, or blood flow restriction training. And this is something that we'll usually do from weeks 2 through 8. We implement it after the incision has healed. And we will do BFR. For those not familiar with it, it looks like a blood pressure cuff that goes around the proximal thigh. It limits blood flow to and from the exercising muscles. If we are limiting blood flow, we are limiting oxygen. If we are limiting oxygen, we can no longer train aerobically for extended periods of time. So it is shifting us into anaerobic metabolism at an artificially lower intensity. So we can do non-weight bearing activities, more of your protocol driven tasks, like your straight leg raises, your bridges, your quad sets, your short arc quads with the BFR on, and we're eliciting that anaerobic response, which is going to start that metabolic cascade. So we get that increased acidity from the lactic acid buildup. From there, we get the pH changes that our pituitary picks up. And that starts the whole metabolic cascade that starts all of the really muscle building that takes place from the hypertrophy training. With that though, because we don't have much mechanical load, we are not breaking down muscle and we're not compromising anything to the graft. And we're also not loading to a point where we may be providing unnecessary shearing forces on that graft. Going into weeks 9 through 12, or I'm sorry, we have some checkpoints here on the next slide as well. These are a little bit less concrete. They should be able to maintain their full range of motion. With this, I like to make sure that they can start getting into some single leg tasks. Something that we'll do with people is like a single leg forward reach to a wall. They should be able to body weight squat for 10 repetitions to parallel. These are things that we have almost developed anecdotally. It's not based off anything from a literature standpoint. They should have no reactive swelling beyond 48 hours. So as we're introducing all these new tasks with them, we don't want them coming back the next day and saying that their knee swelled up or that they had a significant amount of pain beyond what would be just normal post-workout delayed onset muscle soreness. And we're trying to really build this duration of them being able to sustain physical activity for longer than 20 minutes, because in the next phase, we're going to start ramping up our training intensity a little bit. All right, weeks 9 through 12, this is really month 3. Most ACL protocols are going to allow you to run with a patient somewhere between weeks 12 and 16. If we know that we are going to start running at week 12, we need to start preparing them for that task. So in the previous month, the first month, we talked about managing symptoms, getting range of motion back, normalizing firing patterns, and just walking normal. Second month, now we're trying to increase all of the different types of movement we can do. Can we squat? Can we hinge? Can we lunge? Can we do step ups? Can we do all these different body weight tasks? In month 3, all of those different motions that we showed we can do with our body weight, now we're adding external load through them, either through machines or through free weights or through whatever we have at our disposal. At the same time, we're starting to prep them for running as well. So we're really in this like strength building phase right now, but we're also introducing degrees of impact that are not going to be detrimental to the graft, meaning we know that we're going to have to run in a month. So we need to start doing things that are progressing them for the demands of running. We also need to start doing things that are going to increase some of the qualities of running. So we're doing ladder drills, we're doing skipping, we're working on landing mechanics, doing different things along those lines. And when we get to the Q&A, we'll probably have some more questions that lead into that. And if you want to go to the next slide. So, okay, so this one, you don't have access to it. I forgot to mention, I'm gonna follow up this Zoom talk. You're all gonna get our ACL ebook that we have. So you won't necessarily get this presentation outside of just the recording that we have, but all of the videos I have in here are coming from our ebook, and our ebook summarizes everything I'm talking about, and it looks 1,000 times better than what the PowerPoint that I have. So in the ebook, it has this quick little 2-minute video of what our return to running testing looks like. So outside of them just hitting that 12 to 16 week mark, what are we actually looking at from a returning running standpoint? And the things that it includes a Y balance test. It includes a single leg elevated bridge test, a single leg calf raise test, a single leg pistol squat test, and then there is also a bilateral and unilateral stationary hopping test. So when you get that ebook, I would encourage you all to look at that. But really what that's doing, the Y balance test, if you're all familiar with that, it's just a single leg squatting test. So it gives us an idea of what their single leg competency is, but it doesn't really tell us anything with regards to impact because it's just a stationary non-impact test. The stationary hopping test, and what they do is we set a metronome to a beats per minute that they have to maintain for 30 seconds. They do that in a bilateral stance and in a single leg stance. So that lets us know how well do they do with a small degree of impact. With that test though, most of the impact is very ankle dominant. It's a rapid response plyometric that doesn't really take the knee through a very large range of motion. So with that, it gives us an idea of their ability to accept weight with impact, but it's stationary and it doesn't really do much from force production or force absorption. We'll get into that later on. But with the return to running test that we have in the ebook, there's a very good video that Greg Ellis, one of our PTs in Mount Airy, put together, and he did a phenomenal job with it. So we'll switch to the next slide. Weeks 13 through 16, we call it biomotor integration. At this point, this is typically where we're getting into running. So we're continuing to build out our strength training. We've done about 4 to 8 weeks of hypertrophy and strength building now. So now is where we start to get in the weight room standpoint, a little bit more of our strength and power mesocycle. But we're really starting to introduce linear running. So can they jog in a straight line? Once they can do that, we want to gradually increase volume. So maybe you're doing like a walk, jog interval program with them, and you're increasing the duration or the distance that they are jogging and gradually decreasing the duration or distance that they're walking to the point that they're just continuously jogging for X amount of time or X amount of distance. When they can do that, then you start to manipulate the tempo. Can they accelerate? Can they decelerate? Can they do this over a long distance? Can they do this in a short distance? With all of this, you're also starting to advance some of the plyometrics that they're doing. We talked about doing like some landing into our actual plyometrics where we're going through a stretch shortening cycle of going through an eccentric loading phase and a concentric propulsion phase. So with this, we are really trying to focus the introduction and progression of linear running as we continue to build on that strength foundation that we had. With this, I believe we have a couple checkpoints. Nope, we went right into week 17. That's fine. So now week 17 through 20, now we're really in month 5. We've spent a month of increasing our linear running competency. Now is when we are starting to focus more on our multi-directional competency. Can we change direction? Can we do this with different changes of tempo at different speeds? We already know that we can run in a straight line. So now let's make running multi-planar, and we're going to make it more change of direction. This is stuff that you've actually already been doing earlier on. And what I mean by this is you don't wait until 5 months until you finally shuffle with somebody, but you wait until 5 months until you finally shuffle or karaoke or do some things with an you get into month 3, so we haven't been cleared to run yet, but we know we're getting close to it. we've already walked, we've already marched. Now is when we start getting into some light skipping. And when I say light skipping, I mean like casual playground skipping, not formal like A skip, B skip, skipping for height, skipping for distance. Maybe we're going into a ladder and we are doing, I call them cadence drills. I don't call them agility drills, but we're doing, jogging through a ladder, putting 2 feet in each, but we're cueing the patient to do it with a very symmetrical cadence and stance. And I like the ladder because it forces them to be very consistent with how big of a step they're taking. You can have them lead with 1 foot going down the ladder, lead with the other foot coming back on the ladder. Now, when you get into month 4, we've already prefaced that with walking and then marching and then skipping and very controlled jogging in a ladder. Now we open it up on the turf or on a treadmill or outside, and we introduce walk-jog intervals. Throughout that month, we're progressing the distance and the speed and the volume. Then in month 5, you start to get to your non-linear running or more of your multi-directional component to it. When we get into month 6, which is this 21 through 24, from a movement standpoint, we have covered pretty much everything there is. We've shown that we have body weight symmetry. With movement patterns. We've shown we can load that with external resistance and we're strong. We've showed that we can run in a straight line. We've shown that we can run in a straight line at different tempos. We can accelerate, we can decelerate and slow down. We've shown the ability in month 5 to be able to do multi-directional tasks. In month 6, I always said we have done all of that stuff. Now we need to try to do that with some intent, with some higher effort, with some sport specificity tied to it. We add some reactive scenarios to it. And now all of those things that we've done, you've already shown that we can run in a straight line. Let's add conditioning elements to that. Let's start building out what our 300-yard shuttle conditioning test looks like. So maybe around month 5, I already know they can run comfortably. I'm going to have them do a timed 300-yard shuttle at about 50% effort just to get a number on a paper. Great. That took you 90 seconds. Guess what? You're a college basketball player, and to be in the 90th percentile for Division I college basketball, you need to run that in 52 seconds. So if you want to play college basketball at 9 months, we now have 4 months between months 5 and 9 to get our 300-yard shuttle time from 90 seconds down to 52 if you want to be the fastest guy on the court. So you start doing some things. You start doing your conditioning tests in things that they've already shown competency with. So they're comfortable, they're confident, they're not worried about the skill of the test. All they need to worry about is the intensity level and pushing themselves. If we want to go to the next slide. All right, so now we've hit month 6. We are 24 weeks out. We are 6 months out. At this point, this is what our full return to sport testing battery looks like at Rehab to Perform. So range of motion. Now, what I really want to hammer home with this, we're not waiting until week 24 to do this. We've already checked off the range of motion box at week 4, right? We've already done girth measurements at week 1 at the initial eval. We redid the girth measurements at week 4, at week 8. We know the girth measurements are a measurement of swelling and of muscle size. If we already know that the goal of month 2 and month 3 and month 4 is to increase muscle hypertrophy and size, we have already been monitoring that with our girth measurements. So if we're 12 weeks out with an individual and their girth measurements haven't changed since the eval, that's an indicator for us. Do we really want to progress to running if they haven't even checked off this preliminary box? Other things that we're doing a Y balance test. We've already introduced that earlier on. We've done the line hop test as part of our running test. So all of these tests we're doing along the way, and it helps you know, is my person progressing in a manner and at a speed that they anticipate to progress? Or have we missed something with our programming? Or maybe we didn't even miss it, but we just need to start prioritizing other things. Hey, they got their range of motion back really, really quick, but their strength isn't where it needs to. maybe we spend a little bit more time on strength and we get off the foam roller for, the amount of time that we were on it, or we quit with some of the mobility drills. Other checkpoints, the RFESS, that is a rear foot elevated split squat. We do not have a biodex machine at our clinic. We do not have a force plate. We don't have some of these other strength metrics to utilize. There is some very good literature out there that shows the reliability and the reproducibility and the validity of doing rear foot elevated split squats for a measure of not only limb symmetry index, but also just overall strength of the leg. Hop testing is something we utilize. Pro agility is a 5-10-5 agility test. If we have somebody who is a field or court athlete, we will utilize that test. Our 300-yard run is our anaerobic fitness test. Our 12-minute run is our aerobic fitness test. We have a treadmill in the clinic, so we can do the 12-minute run. A lot of times, I just give that as a self-reported test. Hey, go to a track, go somewhere, run for 12 minutes. What's your total distance? You can substitute that out with something else. If you have somebody that runs 5Ks a lot and they know what their traditional 5K time is, have them run a 5K and use that. But really what this is going at, we have a range of motion bucket. We have an atrophy or a hypertrophy bucket. We have several balance tests. We have several strength tests. The hop testing looks at plyometrics, force production, ability to absorb force. The pro agility test looks at multi-directional competency. And then we have two different fitness tests, one skewed towards aerobic and one skewed towards anaerobic. If you do all of this stuff, they test out well with that, you can look this person in the eye pretty confidently and say, we have done very good from a rehab standpoint. You are where you need to be from an orthopedic checklist. You look like you did pre-surgery. You look like all of your peers in your sport. You are good to go. We can go to the next one. Boom, boom. Okay, so this video, and go back one slide, Chris, please. Forward one. Okay, yeah, so the previous video, that's literally just a video of everything I just talked about. So that's Greg. He goes through all the tests, and there's metrics on there of what's quote unquote passing or not passing for those tests. And that is in the ebook. All right, so now 6 months on, this may happen in a PT clinic. This may not happen in a PT clinic. It happens in hours because we have the space and the ability to make it happen. This may be something where you are tagging out to a personal trainer, to a strength coach, or just giving them recommendations on their own. But at this point, this person has shown the physical ability to do everything they need to play their sport. The only thing they haven't done is start playing their sport. So this is where they start reintroducing their sport-specific activities with respect to practicing and scrimmaging in preparation for gameplay. This is the biggest variable in regards to why some people return at 9 months, some people return at 12 months, some people return greater than a year. In a perfect longitudinal linear fashion, you would have them do structured closed drills without any opposition. After they do that and they show that they don't have any pain or apprehension, then you would have them start doing more like one-on-one drills, competition drills, but without contact. If they can do that, you would do those full-speed one-on-one drills and you would add in whatever game-necessary contact there is. If they can do that, you would start doing like team scrimmaging or short-sided or small numbered drills with minimal contact. Then you would go into actual contact. Then you would start playing in actual games, but with minutes restrictions. And then you would go into full play. You may not have the luxury of doing that. It works out great when you have somebody that tears their ACL week 1 of the season. They're not going to play again for a full year. You rehab them for 6 months, and then they have another 3 months before their preseason even starts. And then when 9 months hits, they're actually going through this full progression throughout the preseason. And then once the season starts, they're a year out and you're good to go. For some of this stuff, you may be checking off multiple of these boxes within a practice or within a week or within a month. So I would say the sequencing of these is ideal. Ideal is not always realistic. This is what I would say if we were operating in a vacuum, how I would go through it. And this is where clinical judgment comes into play. Going to the next one. All right, case study 1, looking at time, it's 3:15. We still have 45 minutes. These case studies will take 5 minutes to go through, and then we'll have a good 40 minutes for Q&A and discussion. These were 2 individuals that I worked with that both had isolated ACL tears. They are both soccer players. They both had Dr. Curl, who is the team physician for the Baltimore Ravens. She is phenomenal. She is the medical director for the NFL. And if I were ever to have an ACL surgery, I would have her operate on me, family, friends, anyone who I thought highly of. The only difference, this gentleman is a male, and he is 14 years old, and he tore his ACL his freshman year of high school. He was a high-level high school and club player, has aspirations of playing in college. He is projecting just through the club teams he's associated with that he will play high-level college soccer. He tore his ACL his freshman year. He has parents, coaches who are extremely supportive. There is no pressure for him to return. They basically said, do whatever you think is most appropriate for my son. We are not going to pressure you any one way at all. Surgeon is well aware of what we do at our clinic. She tells us what not to do and then says, you are allowed to do anything else within those guidelines. He underwent surgery on October 14th of 2016. He passed his return to sport testing. So all that checklist we just showed you on April 7th. So roughly 6 months post-op. He did not return to competition until 11 months after surgery. So he took 5 months to go through all of those different things that we just talked about in that 6 months plus category of reintroducing practice and scrimmaging and playing in games. Another example I like to use, Derrick Rose, basketball player in the NBA, he tore his ACL. He was scrimmaging with his team at like 7 months post-op. He did not play in another NBA game until I want to say like 15 or 16 months post-op ACL. He was dominating practices. He was 9, 10 months out. Nobody could guard him. He was phenomenal. He was doing everything he needed to. He did not feel comfortable playing. He just had this mental block. Prior to that surgery, he had other knee surgeries. He had meniscus injuries. He had, I want to say, a couple of ankle injuries. So he was somebody that functionally was very, very good. Mentally, Derrick Rose I'm talking about, he just did not feel confident playing. And he said, I do not want to step on a court until I feel like I have full control. This individual in my case study, he was somebody that the timing of his ACL injury, he said, look, I tore this in October of my freshman year. I'm not going to play anything in the winter. I'm not going to play in my spring season. I'm not going to play anything in my summer club season. I'm just going to wait until September of my sophomore year to play again, 11 months later. So that was something where we just had a very clean, easy timeline to work with. And he's playing in college now. So he's all was good. All went as planned. Now, case study number 2. 20-year-old female Division I collegiate soccer player. She is a starter on her soccer team. She is the high goal scorer, points leader on her soccer team. She tore her ACL in the spring of her junior year. She came out of that injury. She told the surgeon, and she told myself, I have 4.5 months until my soccer season, or 5 months until my soccer season starts. I'm not going to play the first season or the first week of the season, but I am going to play my senior year because it's the last time I will ever play organized sports again. I'm at the very least going to play for my senior game. And if we make NCAA playoffs, no matter what you tell me, I'm putting a brace on my leg. I'm taping it up. I'm doing whatever I need to go out and play. So that was what we were working with. She had surgery May 22nd of 2014. She passed all of her return to sport testing 4 months after surgery. It was unbelievable. Now, keep in mind, this is somebody who was coming to our clinic twice a week. She was also going to her training room every single day and getting more of like the passive treatment. Hands-on work, STEM, she was doing aquatic PT, she was doing a whole bunch of other stuff to supplement this. It was not my idea to take her through all that stuff at 4 months. It was just a game plan that her, myself, and the surgeon said, look, if you want to play, we at least need to take you through testing to tell you if it's even appropriate to play. If we weren't to test you, you're going to step on the field no matter what. So we might as well have some objective data to say, hey, this is stupid for you to go back to play. Or if you do pass the testing, we can say, hey, you're in great shape, but it's just not logical to go back and play right now. And so that we don't get laughed out of the orthopedic world or the sports medicine world for letting you play at 4 or 5 months after surgery, you're going to sign a waiver and you're going to wear a brace and you're going to do everything possible so that we can cover our butts and let you go back and play. So we strike a compromise with her. She did not actually go back onto the field until 6 months post-op. She signed an AMA against medical advice with a physician, and I wrote a case note just saying the same thing, saying, hey, this girl looks great. She's passing all the orthopedic tests. Fitness-wise, she looks good. There's just really no literature to support her saying that she should go out and play 6 months. This is her decision to go out. So she went back and played. She wore a brace. She played in her senior game. She played in playoffs. Never had any issues, and all was well. But that was kind of our mindset of how we triaged that situation. So as you can see, same injury, same surgeon, two very unique situations. We approached them differently, but we still utilized that same return to sport checklist. And in the end, if either one of those individuals were to have an adverse event and have a re-tear, I don't know about you, but I could safely stand in front of a judge or stand in front of their family member or that individual and say, hey, we did everything we could to put you in the best position to get back on the field, or at least inform you of why you're making a appropriate or inappropriate decision to do so. I don't know, go to the next slide. Yep, and that's just a reference slide from there. So, Chris, I don't know what the best way is to field questions. If people, I don't know if they raise their hand, if they type them in, but I'll kind of let you moderate this if you want to.
Yeah, normally it's just a free-for-all, so we don't have that many people. I think whoever feels comfortable either unmuting themselves or typing things out. I think Travis had a question. Do you ever try to get people in for PT pre-op?
I do. Part of this, so sometimes we'll have people come in with a referral from the physician who's doing the surgery for PT. They usually fall into one of two buckets. So they're either somebody who they recently tore their ACL, meaning within like the last 14 days, they are highly symptomatic and they are very impaired from a functional standpoint. So think swollen, bruised knee, terrible range of motion, unable or extremely apprehensive to weight bear. And the surgeon is saying, I want to hold off on surgery until we reduce symptoms and we build up strength so that we go into the surgery in the best physical state that we can. Or it's something where the surgeon says, I don't even have an operating room available for another 3 or 4 weeks. So go to PT and do some pre-PT leading up to that surgery. The other type of patient that I'll get for pre-PT, and this is, if it was my personal opinion, I would recommend it to everybody. Unfortunately, we don't have a Rolodex of people who just, as they tear their ACL, we get the alert and the notification and we can reach out to them and solicit them to come in. But we do get people who ACL injury, they have surgery scheduled, and they'll reach out to us and say, would it be beneficial for me to come in and rehab prior to surgery? If they're the last type of person who's still symptomatic and has those obvious physical impairments, then the answer is pretty simple. Yes, it would be in your best interest to come in. If it's somebody who tore their ACL, but they're walking around, they don't have much pain, they don't have much swelling, I will still recommend them to come in, but it is just a one and done appointment. And usually what I do with them is I say, what we want to do today is get you on a home program so that you can stay active, minimize that deconditioning and just that post-injury atrophy that's going to happen, so that we go into the surgery in the best physical and mental state possible. A lot of the things that you are going to need to do pre-surgery are not that skilled, and they're very tedious, they're very repetitive. So you can do them outside of here as long as you can show me today that you're competent and capable of doing them outside of here and you're not going to injure yourself further. And I'll just give that to you as a home program to do. And the other thing that I try to cover with these patients is I try to put both of us in a very good position post-operatively, meaning, do you know when your surgery is? Do you know when you're coming in for PT after surgery? The most frustrating thing is when somebody has surgery and I don't see them until like 2 or 3 weeks afterwards, when they just didn't know that they could have been coming into PT earlier. I am comfortable functioning in a very acute environment, so I have no issue with somebody getting surgery and coming in 48 hours after their surgery. In reality, if somebody was in a college training environment, they would get surgery at 7 a.m. in the morning and they would be in their athletic training room that evening, just doing passive stuff, getting ice, getting stim, learning how to do gait training, that kind of thing. So I would say the majority of ACL patients I get, they are coming in probably 3 to 7 days post-op. They're returning to their surgeon anywhere from 10 to 14 days post-op to get sutures removed or to get dressings changed. So usually I will see somebody about 3 to 7 days post-op, depending on if there's a weekend thrown in there after the surgery. And what we're really doing is pre-op appointment I had with them, I'm telling them, how do you leverage your time immediately after surgery until I see you again? What things can you do to get the ball rolling? And then when I'm seeing them in that initial appointment, it's really just symptom management and getting them competent and comfortable with weight bearing and starting that whole like neuromuscular re-ed. So Travis, that is my very long-winded rant on, yes, I do see people and recommend seeing people pre-PT, just put them into one of those 2 buckets. I will add, the only thing you need to be mindful of, and I was completely unaware of it until I got into more of like the business side of things behind the scenes. Not all insurance policies are great. Some people only have like 20 visits in a calendar year for PT. So it is not logical to see somebody for 8 visits prior to surgery, and then you only give yourself 12 visits of insurance covered PT post-surgery. And then you're having that awkward conversation of, hey, you need to pay out of pocket, or we need to discharge you. Right? So at our clinic, we verify everybody's benefits before they come in. If we have somebody where the number of visits is not conducive to an optimal PT plan, we plan that out with them in advance. And we say, hey, you only have 30 visits. Periods of time where we can get away with you coming in less frequently. So sometimes when people get out of that highly symptomatic range and they're more just in that strength building range, we may reduce to like once a week or once every other week. So when we get into more of the like higher level movement stuff, then we can see them with a higher level frequency. So that's a game that when you get into the clinic and when you start doing clinical affiliations, pick the brain of your CI of just how they approach that subject.
Did you see Travis's second question, or do you want me to read it?
I did not.
He said, do you ever do any pre-op testing for baseline data on the uninvolved leg?
You can. I think that's logical. I just had, it wasn't an ACL, but I had a total knee come in for a pre-op PT. And with that total knee, I did range of motion and circumference testing on the non-surgical leg. I also did it on the surgical leg as well, just to get an idea. We did a tug. We did a 6-minute walk test. We did a 30-second sit to stand test where we counted how many reps they could knock out in 30 seconds. We did a 6-minute walk test. And we did all of those things, one, to give them something to shoot for after the surgery when they're minimally ambulatory to work back towards. But in theory, if that person's getting a total knee, they should be able to get above and beyond that post-surgical as well. So that is a way, that's the whole reason they're getting the surgery, is to either decrease pain or improve functional ability. So if you can get some baseline testing, I think it's great as a way for them to give them kind of light at the end of the tunnel after surgery. Hey, this is what I need to get back to from a pre-surgical state, but I would love to even get above and beyond that post-surgical to validate and justify why I had the surgery.
Okay, Bert asked a question. He said, how does the treatment change towards the end of treatment where there are more functional goals for those patients who injure their ACL but are not athletes, who are not very physically active?
Cool. And I just figured out, it only took me, an hour and a half. I figured out an hour and a half into it how to pull the chat feature up. So I got the question in front of me. Bert, that's a really good question. And it changes drastically, to be honest with you. So if I have somebody who is not a competitive athlete, or if I have somebody who is not a field or a court athlete. So for example, I had a high school cross country runner who tore her ACL, not running cross country. It was just a freak accident, just on vacation, I believe it was. So for her, I didn't do a 5-10-5. I didn't do some of those other tests that just didn't apply to her sport because they were superfluous at that time. It wouldn't have given us any more information to progress her program. An example of how I might handle like an adult ACL injury. So about a year and a half ago, I had an individual who she tore her ACL doing a box jump as part of a workout. So she's somebody who, I want to say she was like mid 40s, still active, worked out 3 to 5 days a week. She worked out in group fitness environments. So some days were lower intensity days. Some days were more of like your higher intensity interval days. She did some plyometrics. She did some high impact stuff, but she didn't need to do that. So she could, kind of vary what she wanted to do from an exercise standpoint. She was somebody on that return to sport checklist. We did range of motion testing. We did circumference testing. We did Y balance testing. We did the lateral line hop test, and in the ebook you'll see a video of it. But you put 2 lines on the ground, and they're I'm blanking. I want to say 40 centimeters apart, if my memory serves me correct. But it's about 2 feet apart, and they jump side to side on 1 foot for 30 seconds, and they see how many repetitions they can get, and then you compare it to the other side. We did hop testing, but with the hop testing for her, it was just a show me you can do it type test, not a jump as far as you possibly can test. And that had more to do with she wants to get back into doing impact related plyos. So I want to see her doing a test that involves bilateral or unilateral impact related plyos. So with her, we did not do a 5-10-5. We did not do a 300-yard shuttle. We did not do a 12-minute run. With her, I want to say I discharged her at 3 months. When we started running, we cut down to like once every other week. And at 4 months, she had gotten to the point where she was able to pass all of those tests that we had talked about. She was on a return to jog program. And with her, I left it open-ended. And it's what I do with most people. I say, look, here's your home program. You have covered everything I need to say that we've done our job from an orthopedic standpoint. The rest is really just like icing on the cake. So here's your home program. If you would like, we can follow back up in a month just to see where you're at, adjust, modify your programming. And what I'll usually do with most people is I'll have them schedule something out a month in advance. I'll put a little note on their chart, and I'll have our front desk reach out to them like a week before that appointment. And they'll say, hey, Paula, I know this appointment was kind of a placeholder appointment for you. Zach wanted to know how you're doing. And if they say, hey, I'm doing great, take that appointment off, then we just delete that appointment. It's still a week in advance. We have plenty of time to fill it with other patients. Or sometimes they'll say, hey, things are going well, but now that I've been doing some higher level stuff on my own, I have some more questions that I did not have a month ago. And then that's when they come in and we kind of redo their home program. So in regards to that, no, I do not do that whole formal testing procedure with everybody. And the length of time I will spend with somebody is different. I will say it is extremely rare that I would spend less than 3 months with anybody. I like to keep contact with somebody up to the 6-month mark. At a very minimum, it's at least through like home program progressions and just once a month check-ins though.
Do you want to answer Esteban's question?
Oh yeah. In your experience, does a certain graft have better outcomes or better progressions than other? That's great. I was actually speaking with one of our students in our Frederick location about this yesterday. I personally have not had any positive or negative experience skewed towards one graft more than another. And I've seen a pretty good variety of them, meaning it's a pretty even split of what I encounter in the clinic. You will come across some articles that may suggest one graft or another or better outcomes than others. There are so many things that can factor into whether or not somebody has an ACL re-tear that are out of your control and that cannot be controlled by a study as well. So if you're looking at like 2-year re-tear outcomes and they're comparing like a cadaver to a patellar or a quad tendon or a hamstring, and they're looking at 2-year re-tear rates. Obviously, for the sake of literature, you need to have data points and you need to do research just so that it can spark the need for more research and to really deep. But things that you need to consider when you're looking at re-tear rate 2 years out of this, we already know certain things that can influence re-tears. How good was the surgery? Is this somebody who does ACL surgeries all the time, or is this the first one they ever did? Somebody who is more skilled at doing the surgery, I'm going to venture to say, is going to have a lower re-tear rate. How good was the rehab? There was a study that came out the other year that showed it was like 88% of people, and this was a 2,000 patient study, 88% of those patients did not even have any discharge criteria testing done. They were simply discharged based off of how far they were post-op. So only 11% or 12% even used any of the criteria that we just talked about for the last hour and a half. Now, you can go even further. Of those 12%, there's not even a general consensus of what we as PTs think is good discharge testing. So only 12% of us are even doing testing. And of those 12%, you'll go online and you'll hear PTs berate other PTs about, oh, well, you used a biodex as opposed to a rear foot elevator, or you used hop testing, and hop testing doesn't account for the deconditioning effect. And my response to that is, well, guess what? The 12% of people that took the time to do that testing are already doing more than the other 88%. But we do need to, as a profession, do a better job from a testing standpoint and get a more holistic cluster of tests to help minimize some of those shortcomings of all the tests. I will agree. Some of the tests that we do, they're not great, but no test that we're going to do is great. So now let's take that a step further. Of these people that are having the re-tears, if I have somebody that I work with for 9 months and I take them through all this testing that we really don't even know if it's the best testing or not, but they get back into great shape, if for the next 15 months they don't do anything and they just sit on their butt, they get COVID or they get the flu and they don't do anything for 3 months, and then they never get back into their sport, and then at the 2-year mark they jump back into a sport and they re-tear their ACL, is that really the fault of the patella tendon graft or the cadaver graft that they had? Or was it one of the risk factors we already know that they were deconditioned and they had poor physical fitness standpoint? So that's kind of me standing on my soapbox, but I would say no, I haven't seen an increase in incidents in the clinic, just in the setting that I operate in. And I may be a little bit biased myself because we do see a lot of consistency from the surgeons that we get ACLs from. So we are a little bit more controlled than maybe a group that's seeing ACLs from 100 different surgeons. And then the other thing that I will say to answer the other part of that, though, is you do have to definitely respect the type of graft in regards to exercise selection and how you're progressing different activities. Meaning, if I have a patella tendon graft, I'm going to be more mindful of maybe the volume and the intensity of quad loading or knee dominant activities I do with that person, more so than what I would do with a hamstring graft. Conversely, if I have a hamstring graft, I may be more mindful of like the posterior chain loading that I do with somebody. It doesn't mean that I avoid doing it, but if I do it with somebody, I'm really making sure I'm honing into what was the intensity, what was the volume, what were the training parameters I had on that. So if this person does flare up, I know what was probably the most likely cause of that. So I would say the graft has more to do with your selection of exercise and maybe your, I would say how careful or conservative you are with introducing certain things that will stress that area. But I would say in my experience, and I've only been practicing 8 years, so you could ask me this 10 years from now and I may look back at this little Zoom podcast and realize that I was pretty foolish. But in my experience right now, I do not have a preference of a type of graft.
Awesome. Thanks, Zach.
And it looks like Nick had a question. What ways are you focusing on the uninvolved leg throughout the rehab process to help with limited deconditioning, ensuring you're providing enough overload while not risking re-injury of the involved leg? That's a great question. So with this, I would say I don't do anything to specifically target the other leg early on. I'm more focused on trying to get the surgical leg to match that other leg as quickly as possible, meaning in the first like 1 to 2 months. And really that comes down to, I'm less worried about deconditioning the uninvolved leg in the first 2 months when I have a surgical leg that still has sutures in it and a lot of swelling and a lot of bruising and we can't fire a quad. So I think this is where we don't want to get too cute and ignore the actual problem at hand. So early on, I'm still focusing on kind of tunnel vision, PT school. Let's address this ACL injury, but I'm focusing more on reconditioning of the total body. So as soon as they can make a revolution on a bike, which will happen within the first month, I will have them do long duration, low level work on the bike. So we'll do 15, 20 minutes on the bike. That may not happen all in clinic, or I may stagger it where I'm telling them to come in early. So if they have a 3 o'clock appointment, I'll say, hey, come in at 2:50 and do 10 minutes on the bike. And then at 3 o'clock, we're spending our time doing supervised work with them. And at the end of the session, I'll say, hey, do another 10 minutes on the bike. Or we're doing things like push-ups or planks or TRX rows or things where we can keep almost like total body circuit training, but it's not really firm stance. When we get further out and we get into like that 3, 4, 5 month mark, I honestly go back and forth. And I talk to a lot of other people, and I go some weeks where I think, hey, you know what? Other leg, you know, maybe we're doing, maybe we're leveraging some of our machines that we have, and we're doing like single leg presses with the uninvolved leg as much as we can, or hamstring curls or single leg wall sits, and we're trying to go to failure or exhaustion on the other leg. And then other times I think, I mean, are we really just widening the gap if we're doing that too? So it's something where I think you always need to be mindful of. I'm always going to try to get back to even and limb symmetry first while maintaining just overall fitness levels. And then once we train limb symmetry index, then it's just, let's get after it. And once we have two legs that look the same, in reality, if we're only 4 months post-op and we've achieved that limb symmetry, we're not doing anything competitively for another 5 months. If we can't get back to our previous conditioning states in the next 5 months, then there's either something we've overlooked, or maybe we're just not really as good at strength and conditioning as we thought we were, and we need to tap out and get some other people. So it's tough. In my personal experience, those are my thoughts with it. I think the biggest thing that you need to monitor with that is just make sure that you're actually tracking deconditioning to make sure that you are moving in the right direction as you go.
Thank you very much for that. In what ways are you tracking that deconditioning along the way?
A lot of different ways that you could do this. Honestly, one of the most simple things that you can do is monitor resting heart rate early on. So that may be something where, like, you may not know what their resting heart rate is pre-surgery, but if you have somebody that's a 20-year-old athlete and their resting heart rate is 105, we probably need to do a little bit of aerobic work with them. Or if you have somebody that is ambulatory and you're doing a bike workout with them, and you're doing what you would consider off the intensity of the bike workout, or maybe you're doing like a 2-minute step test with them, and their heart rate shoots to 170, doing steps at like a 1 step per 2-second cadence, that's an exaggerated response for a very low level thing. So that would be somebody that I would want to spend a little bit more time doing some aerobic exercise with. Other deconditioning things, it's something where you'll find more clues on what you can use and what's valuable to you based on what you can find. But it's kind of funny, a lot of the PT school stuff that you learn, like the tug, the 6-minute walk, the 2-minute step test, a lot of these like baseline functional ambulatory stuff, I won't formally do them with a lot of people, but you can get a lot of information from that. So like, I'll do an informal 2-minute step test with somebody when maybe somebody's like 5 to 8 weeks post-op and they've already shown that they've been walking without an assisted device for 3 weeks at this point and they're fine. That's somebody that in their workout routine, when we're in more of like that strength building phase, I may supplement some of their strength building work with, hey, in between this, we're going to do a minute's worth of step ups onto a step. Then we're going to go back over into the gym and we're going to do our goblet squats where we have a 30-pound weight in front of us. We're squatting down, tapping the box, standing back up for our set of 10. After you do that, we're going back over, we're doing another minute of step ups on an 8-inch step. So there are things that you're kind of building into programming and monitoring as you go. So I know that was kind of a very vague, it depends answer, but hopefully that gives something of value.
No, that's great. Thank you so much.
Yep.
Zach, are there, within the past few years, is there any big kind of shifts in your approach to ACL rehab? Or maybe if that's too small, within like the past 5 to 8 years since you graduated, of like, I'm definitely not doing that anymore, or different like standards that you've set?
I would say there's less things that I've gravitated to or have gotten away from. But I think what I hope I've been doing is becoming more efficient at when I stop doing things, meaning we have maximized benefit of doing X, Y, and Z. Let's move on to the next trait or to the next category. An example of that would be like, think about like balance training. So, early on, can I stand in a tandem stance? Can I do that with my eyes closed? Can I do that with cervical motion? So can I go through like a Romberg, sharpened Romberg type thing? Can I stand on one leg? Can I stand on one leg with my eyes closed? Can I stand on one leg and catch a ball back and forth? Have I done just some single leg balance drills to make me confident to do a single leg touchdown or heel tap or some sort of like single leg activity in the gym in the upcoming weeks, can I do single leg training with a perturbation? Can I do it on a compliant versus a non-compliant surface? All of those things, I think what I was guilty of early on is I would just keep adding more layers of complexity to things, and it wasn't really giving me anything back. Meaning like, can I balance on one leg? Awesome. Let's make it harder by closing our eyes. Great. Let's make it harder by closing our eyes and being pushed. Let's make it harder by closing our eyes and being pushed and standing on a wobble board. Let's make it harder by, and I just kept adding layers of complexity, which, not to say it wasn't worthwhile, but in the meantime, I could have been spending that time building up more of some of the strength bucket that wasn't filled yet, or some of their fitness metrics that haven't been filled yet. So what I would encourage all of you to do is, it goes back to one of those earlier slides I have. Define, what is your end game? What are you trying to accomplish with this patient? Meaning what sport or activity, or what does this individual, this weekend warrior, want to get back to doing? What are the qualities of that sport? If they want to run 5Ks, what does running involve? It involves strength, it involves endurance, it involves single leg stability. What physical tests do I have to measure those qualities? And then with that, are they actually passing those tests, or am I programming appropriately to be prepared for those tests or be prepared for that activity? So I think that is just what I would say. I hope I've gotten more efficient with since I graduated back in 2012, is clearly defining what they need to get to, establishing what test is going to make me comfortable saying that they are appropriate to do that, and then figuring out how hard do I need to train leading up to that test. And then you can go down the whole other rabbit hole of, make sure that you're not just programming for a test, and make sure that your programming has context in the bigger picture, and people aren't just passing tests because they're getting that learned effect where they're practicing it for 3 or 4 months and they're becoming robotic with it. And that's what crushes me when I watch all these like YouTube videos of people training for football, and they do a choreographed dance in an agility ladder, and they do an 80-inch vertical jump onto a box, and they do all this different stuff that's choreographed and anticipatory. And I go back and I'm like, hey, all that's great, but it doesn't involve contact. It doesn't involve reaction. It doesn't involve a lot of these other things that we need to go to. And did we really need to do a 3-minute agility drill with 10 different perturbations and pieces of equipment? Or could we have already crossed that box off, 2 months ago and just gone on to something else? So Dr. Funk, the owner of our clinic, he uses a very good term that I'm going to steal from him, and he calls it capture and keep. As you're going through this process, as you accomplish one task, or as you capture one ability, keep it and move on from it. Meaning early on, when I regain range of motion, awesome. Once I have full range of motion, I don't need to keep doing heel slides for the next 9 months. Now, if I start progressing and I'm losing range of motion in the next month, that's probably indicative of me with a training issue, meaning I'm probably pushing too hard or doing too much. And I have pain or swelling that's now causing me to lose some of these things that I had already accomplished. So I would keep that in mind. Figure out what you need to do, determine what metric satisfies that, capture it, and then keep it as you move on to the next thing.
What are your thoughts on the differentiation between return to sport, return to play, and return to competition?
Controlled chaos continuum is really what it comes down to. So, we have return to competition is what I review as just like, hey, that's me stepping on the field, doing whatever I want at any time for as long and as much as I want to do. So think of like a youth athlete going to a tournament and playing 5 games in a weekend of lacrosse. Or did they even play lacrosse in Texas? All right. I say that sometimes the people in Utah are like, what the heck's lacrosse? And it's like the big thing out here in Maryland. So that's what I view as like return to competition, going back and doing whatever your desired activity is with no limitation at all. Return to sport or return to activity just means like you're getting back into the environment, but we still have constraints. And I think it's a matter of we return to activity first within the context of our sport, and we gradually remove constraints, or we add more layers of complexity or more layers of chaos until we're basically mimicking what a whole game-like environment looks like. And that all comes down to, what time frame do we have to do that in? Baseball gets kind of I don't want to say a bad rap, but baseball gets that rap of being very archaic. And I have Tommy John, and I'm going to go out and I'm going to throw 20 pitches today. And then the next day or the next week, I'm going to throw 40. And then the next week, I'm going to throw 60. Then I'm going to go from flat ground to a mound. Then I'm going to go from throwing off of a mound of only fastballs to throwing changeups. Then I'm going to go from fastballs and changeups to throwing curveballs and breaking pitches. Then I'm going to throw in a bullpen session. Then when I come out of a bullpen session, I'm going to throw in a game, but I'm going to have innings restrictions. Then I'm going to be able to throw as many innings as I want. And it ends up being this like 18 to 24 month process. And a lot of people argue like it's so long and it's so regimented and it's too protocol driven. And it may be, but guess what? It's very easy for them to pick up. If somebody has pain, it's very easy for them to figure out, was it because we increased volume? Was it because we changed from flat ground to mound? Was it going from fastballs to curveballs? And baseball is one of those sports where they usually say, I don't care what the sense of urgency is. We have a structured timeline and we're just going to stick to it. Where it's funny, you have other sports like hockey or football where you get the injury report. It's like it's day to day, or it's doubtful, or it's questionable. And those are the people that maybe they don't have an ACL, but they have an ankle sprain. And today it's like, hey, let me see if you can jog in a straight line. Awesome. You can do that. Perfect. Now try to do a figure 8 or a slalom run. Perfect. Now run out 20 yards, plant, run back. Great. You can do that. Now do it a little bit harder. Awesome. Now run a route. Great. You could run a route. Now run a route with somebody guarding you. And they're literally going through this progression within the course of a practice. And it's almost like a day-by-day progression going through that entire controlled chaos continuum that we talked about. Some people take 5 months to go through with an ACL. And you can also, that's something, literally just gave you an example of what I would do with somebody with like a hamstring strain or a sprained ankle who sprains their ankle or pulls their hamstring on like a Tuesday, and they're trying to figure out if they can play in a tournament on Saturday. I'll say, hey, we're going to go through a low-level workout in here, and we're going to gradually ramp up the intensity of the complexity of the workout, and we're going to see, what's the straw that breaks the horse's back? Is it when we start ramping up speed? Is it when we start introducing multi-directional work? Is it really when we open up our stride and start sprinting? But you don't really know where that is until you test it. And if it's one of those things where you say, oh, you have a pulled hamstring, tissue healing timeline, say it could take 4 to 8 weeks. We're going to wait 6 weeks to do it. And you wait 6 weeks and they feel great. You don't know if you just wasted 6 weeks and they could have been back at 4 weeks. If somebody waits 8 weeks and they're still painful, you don't know if it's because of tissue healing or you didn't program them properly. So that's where you get into like the art versus the science of PT. And you really it's the constant risk reward of what's my situation, what's my confidence level with pushing this patient, and what's the worst thing that can happen if we have a little flare up? Is it something where it's just going to be sore for 12 hours and we're right back where we need to? Or is a flare up going to reset the time frame for another 4 weeks? And now we went from missing 4 weeks of our football season to 8 weeks of our football season.
That was great. I know you have to go in a minute, so
Yep.
That should probably be the last question. But this was great, man. Thank you so much.
Yeah. Did we have? If you have any other questions, shoot me an email. And what I can do is I can just do like an IG live or something. I'll just video myself recording it. I'll post it on Instagram on my page, and you guys can look at it there. I do a lot of just educational content on my Instagram account. A lot of it is ACL heavy. And I reference a lot of other really good ACL resources on there as well. So like my Instagram is ZDBaker30, Zachary Daniel Baker 30. Some other really good ones. Wesley Wang is somebody who he works like 40 minutes from me, and him and I collaborate a good bit. Ignite Physio is out on the West Coast. He does really good work. Move Strong Physical Therapy is a guy who works with Eric Cressy up in Boston. So there's a lot of really good people. And if you make your way onto my site, I can help kind of filter you out. And our R2P Academy site has some other ACL and just general content that you can get as well. Chris forwarded me all of your guys' emails, so I will try to not spam you guys. If you get annoyed by emails, just unsubscribe to it. But I will send you our ACL ebook. And we also just developed an ebook for concussions. Paula McCorkle, she's at our Germantown location. She is phenomenal with concussion rehab from like a vestibular, neural, cognitive standpoint, but also integrating that with strength and conditioning stuff. So you will get our ACL ebook and our concussion ebook. It's going to just throw you in with all of our emails on our R2P Academy. So I apologize if you get annoyed by the emails. Unsubscribe. You're not going to hurt my feelings with that. But that will be just something that you can reference back to.
Sweet. Thank you so much, Zach. I really appreciate it.
Yep. Feel
Thank
free
you so much.
In the future, if you guys or girls ever want to talk shop, reach out to me, social media, reach out to me via email, drbaker@rehabtoperform.com. I'm very active and involved. I love doing this kind of stuff. So you are not taking time from my schedule or bothering me if you want to expand on any of this stuff in the future.
You're the man. All right. Thank you, everyone, for joining. I'm going to close it and then finish the recording.